Hi everyone, Dr. Traci Moreno, psychologist, and today in our therapist and training series we're going to continue our discussion on suicide risk assessments, and we're going to talk about what to do once you determine the risk level for a client, whether it's high, moderate, or low risk, kind of like what to do then. And let me say that if you do work for an agency or anybody else, they are going to have a very specific procedure for this that you need to follow. So make sure you are following that, and this could just be additional information for you, or if you eventually go out on your own, this could be very helpful for you to be able to come up with your own plan. So with their risk, so let's go over high risk first. So if you find that they're high risk, I always want to ask the client first and say, okay, thank you for that information. Now, after what we've talked about, what do you see your level of risk being? I think it's really important to get their awareness of their own level of risk, because they could potentially say, I'm at pretty high risk. It sounds like, or maybe they didn't have the awareness at first, but after going through and talking about their experience and all the questions that we're asking them, they could say, well, after this discussion, it probably seems like I am at high risk. Or they could be, so this is also assessing their insight, their awareness, and judgment. So, ask them what they think their risk level is before you give them your assessment, and then you can give them your assessment. And then you would need to let them know that you are going to have to call 911 and ask them how they feel about this, right? Let them process that, because the goal is to get their buy-in of being able to go to the hospital for further evaluation. It's not a guaranteed 72-hour hold or anything like that. All it normally is, unless you work for an agency that does that, and then they're going right over. But be educated of what the process is for the client on their end, so that you can educate them on that and kind of help ease their fears, because the fear, right, all of our fear is usually the unknown. So the more we can make known to them, but we want to make is better, but we want to make sure that the information we're giving them is accurate. Okay, so do that. Ask questions to your supervisors, or find out what the client will go through once they leave you. So you want to tell them you need to call 911 because they're at a high level of risk, and it's really important because you need to keep them safe, and ask them how they feel about that. Let them process that, right? Regardless of, even if they say, I don't agree with this, I don't want to go, you can say, I understand, I can only imagine how scary this would be, things like that. But that doesn't, allowing them to process how they feel about you making the call doesn't change your decision at all to call. You still need to call regardless, but allow them to process their fears about it, and then educate them as much as possible, right? And say, well, usually, from what I know, I kind of put those kind of blanket statements out there just in case, procedures change over time, or something else different happens than you told them to, that, you don't want them to come back and say, well, you told me this and that's not what happened. And, because then that could break the trust between you, and you don't want that, because, upon discharge, they're probably going to come back to you. So you want to explain your understanding of what will happen from here. Most of the time, when I worked for agencies, and in private practice, we call 911. Some places prefer to call like an emergency response team, but that could take hours. I mean, sometimes half a day, a whole day. And we don't have, in private practice, we don't have a place where the client can wait or anything like that, or for somebody to wait with them. So we just call 911, that's the quickest. We do make sure that when you're calling 911, you let them know immediately that this is not an emergency, but that you have a client that is at high risk of suicide and you need them to be taken to, the nearest emergency room to be further evaluated. And that's what you'll explain to the client, right? You say, okay, this does not mean you're going to go to the hospital. It doesn't mean you're going to get held at the hospital or anything like that. All that's happening right now is you're going to go for further evaluation, right? That's it. The paramedics, possibly the police assist them, but it's primarily the paramedics are going to come. They're going to take you to the emergency room or an assessment center to just be further evaluated. And then they're going to determine whether you need to be held, 1, 2, or potentially 3 days. So to be further evaluated. And you ask them, and again, asking them, how do you feel about that? What are your fears? Imagine that being you and how you would want to be treated in that moment. It's already bad enough that you're in that state of mind of wanting to, hurt or kill yourself. So make sure you're continuing as a regular therapy session with your sincerity, compassion, unconditional positive regard, right? I have seen a lot of therapists just kind of shut down and go into business mode whenever they have to, whenever the session turns into where something that breaks the limits of confidentiality and they have to do an abuse or neglect report or a 911 call for a suicide risk or something like that. So try to continue to maintain your compassion as you would. This is, you're still in a therapy session here. Also, I want to say that if the client wants to leave, they can leave. We cannot hold them against their will, right? That would be kidnapping. So we don't do kidnapping. So if the client wants to leave, they can leave. We still call we tell them that's okay. That is your right to leave. I'm going to let you know I still need to call 911 and I'm going to have to give them your home address and they'll probably follow up with you at home. Usually when you say that, they go, okay, I'll stay, because they don't want the ambulance and police going to their house, so. But again, that's up to them. Also, you would try to give them, when you call 911, make sure make sure they know it's not an emergency. They may ask you, one of the biggest things I was always asked is your patient going voluntarily, or they want to know what their risk is. And this all just also determines if police are going to back them up, right? So and this is all before we're even making the call. This is just in the conversation between me and the client. I talk to them about this. I go, look, I know, regardless, I understand you're scared and I don't want to make this an even worse situation for you. So I want us to work together, right? Because regardless, I have to make that call, right? But I'm telling you that they're going to ask me if this is voluntary or not, or if you're not wanting to go. And they could perceive that as, a potential threat. And then they will come with police also. Sometimes it's standard for them to still come with 1 or 2 police officers, but I've seen them when somebody was not voluntary or a little volatile or aggressive about it. I mean, they've come in and police were first, and that's traumatizing for a client. And then you think of, okay, what happens in the future? They're going to be really hard pressed to ever report this to another therapist, right? So you've got to think of all of these things. So let them know and just say, it's going to be a lot better for you if it's voluntary, because you're going to have to end up going anyway. But this way, the whole process could be just a lot easier for you. And just remember, this is for your own safety. Okay, so moving on, allow them to process how they feel about each step. Call 911 to report that you have a client that appears to be at high risk for suicide. And if they leave, you would, also when you call, make sure you get the name of the person you spoke to, make a note of the time and the date, because you're going to want to document all this as well. Then if the client is future oriented, ask them do you want to, let's make sure you have a follow-up appointment on the schedule. That's future orientation, right? Which is a protective factor. So if they're willing to make an appointment with you, that is, an indicator that they are going to still be alive by then, right? They're not going to attempt suicide right now. So hopefully that's an indicator, right? Not a guarantee. But again, we're kind of adding all of these things up. So make that plan for a follow-up appointment. And then at the next appointments, that's when you're going to go into the suicide prevention plan. And we will go into that further in a coming up episode. Okay, so let's talk about moderate risk. So for moderate risk, you want to encourage them to safely take themselves, right? So now it's not a guaranteed that you have to make the call to 911 regardless, right? So now we're moving down a level where you want to encourage them to either take themselves safely to the nearest emergency room to be evaluated. Sometimes I'll even offer, do you want me to, I can write a letter of, my concerns and request that you be further evaluated for suicide risk, something like that they can take with them so they don't have to verbalize everything. Or, have a loved one. Is there somebody that I can call? You do need to, at a moderate level, you do want to call their emergency contact and then get them involved as well. This would also be at high risk, right? So you need to let them know that. I usually just verify who that emergency contact is, because sometimes when they initially do the intake paperwork, that emergency contact, it might be an old contact or somebody they no longer have that relationship with or something like that. So just verify that contact. I like to do those calls on speaker with the client with me. But I ask them, I give them the choice. Sometimes they don't want that. So I will ask them what they prefer. If they'd like me to talk to, that person privately, or if they want to do it on speaker. I always encourage it to be together on speaker. Even better is to have them call with you on speaker. That's always the best situation, because you want them taking control and empowering themselves in their own treatment and in asking for help. And you want to let them know in that call, you're going to let them know about their risk factors, possibly if there's a plan in place or the means, and you want to brainstorm with their emergency contact and the client to how can we eliminate or limit their access to those means. And of course, you're going to document all of this. And then you let them know you want to make sure you give them resources to, any websites, any internet, any support groups on the internet, any actual live support groups in the area. There's a suicide hotline. There's a text line, which is super easy and great for people. Make sure you have like resources already typed out that you can just hand to them at any time, and encourage them to use those resources. I even kind of like, not full on role play, but like I go through like a role play of like, okay, what do you tell them? Because I've also gone where I've given people resources, and then on their next session, I say, they tell me maybe like the thoughts are still continuing. I ask them if they used the resources that I gave them, and they say, well, I didn't know what to say. And I'm like, oh, because, and this was when I was starting out, and now, now where I am, I realize that, when you're in this dark place, you don't have the resources yourself to problem solve, to figure things out like that. So everything has to be as concrete as possible. So you just tell them, you say, so you go through that conversation with them and say, all you have to do is let them know that you're not feeling, you're feeling like you want to hurt or kill yourself, and they should be able to take it from there. But you got to open it up and just tell them. Or even if you can just get out, I'm scared and I feel like I might hurt myself. or something like that. And you ask them, like, what do you think you would be comfortable saying? And then the person on the other end should have enough training to kind of roll it from there, but just give them that opening statement to get that conversation started. Okay, so let's see, let me go through. Yeah, and again, you're going to follow up with that suicide prevention plan just like you would at high risk. Okay, so last one, let's talk about low risk. Low risk, you want to talk to them about, even though you're low risk, we still have to take this very seriously. You want to encourage their, strength-based protective factors, things like that. And you want to follow up with creating a suicide prevention plan. And again, we're going to talk about that plan in detail in a coming up session. So if you have any questions, concerns, any other thoughts or ideas you want to add to this, please feel free to add that in the comment section. All right, thank you so much. Bye.